So hi everyone and welcome to our 8th Revolutionizing Healthcare session. My name is Nick Maxfield. I'll be moderating today's session and I handle the Schaar Lab's communications. We're also joined by Mihaela van Schaar, who will be in charge of the roundtable and Q&A for this session. And of course, with us today, we have a panel of 4 clinicians who I'll introduce in a minute. But first, to give you an idea of what to expect from today's session, as always, our purpose with Revolutionizing Healthcare is to build a shared community and develop a common language by defining and understanding medical problems through the use of formalisms and by mapping these to AI and machine learning solutions. In our previous 2 sessions, our 6th and 7th session, we had a pair of roundtables on interpretable machine learning for healthcare. These were fantastic sessions with a lot of engagement and insight. I'd highly recommend watching them. And we do actually have a new piece of content coming out about these in the next couple of weeks. But today's topic is personalized therapeutics and individualized treatment effects. And this will also be a roundtable. To give you an idea of how this breaks down time-wise, after my introduction, we'll have a brief presentation on this topic by Mihaela. And then we'll go to our roundtable with our panelists. And Mihaela will handle this as a kind of a guided discussion where she will introduce some topics and questions that will be handled by our panelists. And then if we have time, we'll go to an open Q&A and discussion session. And the only reason we might not have time is if the roundtable itself is particularly fruitful and we don't want to interrupt it, we'll just let it run and we'll take the questions that we get from the Zoom chat and hopefully bring them up in a subsequent session. So if you do have any questions for Mihaela or for our panelists, you can post them into our Zoom chat at any point in the session. Don't message us individually, though. Please send them to everyone. So please do feel free to share questions at any point in the session, not just during the Q&A. Actually, the earlier you share them, the more of an idea we'll have of what kind of questions are out there for us to handle. And do let us know if you need to leave before the Q&A session, in which case we'll read your question out. And we do want to limit ourselves to questions from practicing clinicians if at all possible. We expect this session to run for just about an hour, 10 minutes. Okay, so now let me introduce our roundtable panelists for today. We have 4 panelists who kindly volunteered their time to join us today. First up, we have Camelia Davitian. She's clinical professor of medicine in the Division of General Internal Medicine at UCLA and the Director of Women's Health at the UCLA Comprehensive Health Program. Then we have Eoin McKinney. He's University Lecturer in Renal Medicine at the University of Cambridge and an honorary consultant in nephrology and transplantation at the Cambridge University Hospitals NHS Foundation Trust. We also have with us today Lucas Fleuren, who is a PhD candidate in AI for the Laboratory for Critical Care Computational Intelligence at Amsterdam UMC, where he's also a resident in the Department of Intensive Care Medicine. And finally, we have Neil Navani, who is an honorary associate professor at UCL, where he's also a consultant in respiratory medicine at the UCL Hospitals NHS Foundation Trust. Now, before we go through to Mihaela's introduction on our topic, I do need to give a kind of disclaimer up front, and this is related to the fact that we can offer continuing professional development credits or CPD credits under the Royal College of Physicians scheme, and you can get 1 credit per session for participating in these sessions. But in order to do that, I need to kind of read a little disclaimer to the effect that this is a non-commercial, no-fee event organized by our lab independently from our research sponsors, that we don't have any conflicts of interest such as financial relationships that would undermine the balance, objectivity, or scientific rigor of these sessions. And we won't use these sessions to promote products or services. If we do mention one of our research sponsors, it will be strictly relevant to the academic content of the session, and we will make sure that we acknowledge such a relationship when a mention is made. If you do want to know how to claim your credits, please just wait until the end of the session and I'll give you a guide to how to do that. So next up, we have our presentation by Mihaela. She'll be introducing the topic of personalized therapeutics and individualized treatment effect inference. So Mihaela, if you wouldn't mind going ahead and sharing your screen. Thank you.
Wonderful. Thank you so very much. So thank you everyone for joining us again today. I'm going to start by briefly presenting the topic of personalized therapeutics and what we believe that machine learning can do to empower you, the clinicians. The focus will be mainly on describing the key formalisms and concepts and the key ideas. So what do I really mean by personalized therapeutics? The focus is on estimating the effect of a treatment or an intervention on a specific patient given their unique characteristics. So for instance, I have here a hypothetical patient, Mary, that was just diagnosed with a particular disease. Let us assume breast cancer. And the question is, given her unique characteristics, what is the best timing and treatment intervention for Mary? And what is best with respect to potentially multiple outcomes of interest, and inclusively the decisions that Mary herself may want to make? So for that, in order to provide such personalized therapeutics, we are estimating treatment effects at the individualized level. So again, I have here Mary with some information that was gathered about her diagnosis time. And we are training, as I'm going to tell you a little bit later, machine learning models that can predict what will be the effect of different types of interventions on the individual patient, Mary. For instance, one of the things that we can do is we can estimate what will be the effect of giving to Mary chemotherapy after surgery or giving no other treatment besides surgery. We could look at this effect of the treatment chemotherapy with respect to multiple outcomes. One of the possible outcomes could be 5-year survival. We could also look at other outcomes as well as competing risks. What's the probability of Mary from having side effects or dying from another cause? In addition, we could look not only at chemotherapy, but combinations of chemotherapy plus radiotherapy, and also what type of chemotherapy we can give to Mary. This is not only the case for just decisions on treatments, but also inclusively dosage. So what you see here on the right-hand side is, again, individualized treatment effects with respect to continuous outcomes such as chemotherapy, where the chemotherapy dosage could be personalized as well. And again, we can look at just one outcome of interest, probability of survival within a certain time, or we can look at competing risks and side effects as well. In addition, we can look not only in a static setting, but also in the time series setting. As the patient is evolving through her disease, when shall we start treatment? When shall we stop treatment? What combinations of treatment we should be giving and when? So the decisions being made not only at one time, but also over time, and implications of different treatment plans for the patient at hand. So what is happening here? We are trying to go beyond clinical trials, not replace clinical trials, but rather understand that there are limitations to randomized clinical trials alone. We know that current treatment decisions are often based on the average effect of a treatment or observation as observed in a randomized controlled trial. But we know also that treatment effects are often heterogeneous. So just looking at average treatment effects will not always be informative for estimating individualized treatment effects for the patient at hand. So some of the disadvantages of using randomized controlled trials alone for doing personalized therapeutics are that they are recruiting non-representative patients, often patients that are elderly or conversely very young, or may have multiple comorbidities, may not be enrolled in such randomized controlled trials. They are also often focused on very specific questions and are unable to capture the complexity of healthcare, where patients are at time given different treatments over time, are taken from one treatment and set to another treatment, and potentially we are interested in multiple outcomes over time. Also, they are expensive and often just enroll a limited number of patients. So it is complicated to learn very specific effects from such small sample sizes and provide recommendations about personalized therapeutics with sufficient confidence. They are time consuming and have high cost. And also at times, some type of trials cannot even be conducted because it would be unethical. So a complement to that is to, after a drug or intervention is approved, to complement this with learning from observational data to estimate individualized treatment effects. The advantage of this is that we can learn from real-world observational data. We are able to capture the complexity of healthcare. We can do that at scale from a variety of data sources. And if we are capable to do this successfully, it will enable for fast, cost-effective deployment for decision support systems for you, the clinicians, on behalf of the patients that you have in front of you. Why is this problem different than many of the problems where you have seen machine learning work so far? We have heard already quite a lot about what I call supervised learning, predictive analytics, where, for instance, on the basis of imaging, we predict whether a patient has cancer or not. The problem that I'm going to describe here that enables personalized therapeutics is different and a lot more complicated than just supervised learning, where we make predictions or prognostic scores. It is a causal effect inference problem. So we have a patient with their confounding factors, we have interventions, and we have outcomes associated with them. And this is not a prediction problem, but rather a causal inference problem, where we can ask ourselves what would be the effect of taking different types of interventions on the patient. So we are asking what if questions. We are aiming to answer causal effect inference questions and compute counterfactuals. We are trying to use observational data as shown in here as the training set, where we have patients that have been, just for simplicity, I'm going to consider just binary treatments, but as I mentioned to you before, we can go beyond binary treatments into multiple treatments and even continuous treatments. But here in the training set, I'm just highlighting patients in red that have been treated and patients in blue that have not been treated. We are going to learn on the basis of such observational data and try to estimate the effect of interventions given the unique characteristics of the patient. So we want to ask causal inference questions and determine on the basis of the features of a patient, what is the best intervention to take. We can also ask counterfactual questions. What would have happened to this specific patient if we would have intervened in a different way or at a different moment in time? So this is a complex machine learning problem because unlike in a supervised learning problem where we have a very clear label, here we do not have a very clear label because we miss the counterfactuals. So we need to learn in the absence of counterfactuals. So we don't have true supervision. So this is why these causal effect inference problems are a lot more complex for us, the machine learners, to deal with. In order for this, to further highlight the challenge and the difference to just predictive analytics, let me also say that we need to carefully model the intervention. This is not just another feature. How, given the unique characteristics of the patient Xi, we should model the intervention Wi, and look at the outcomes resulting from this decision of intervention. Also, often we deal with what is known in the statistical community as selection bias, which leads to covariate shift. We know that you, the clinicians, don't close your eyes and do a randomized controlled trial when you see a patient with unique characteristics Xi. You use your own judgment. So this leads to a selection bias. So if it is to learn from electronic health records, for instance, or other observational data sets such as registries, we need to learn in the presence of such selection bias. These two challenges highlighted here, again, make a difference and a contrast with just supervised learning. Usually, this type of causal effect inference for estimating individualized treatment effects is often solved and casted in the context of a framework that was introduced almost 100 years ago, so quite a long time ago, by Neyman, and it was later augmented by another famous statistician, Rubin, and that creates the potential outcome framework where we learn from observational data, such personalized therapeutics. We have patients with their unique features XI. We have treatment assignments. Here I'm just for simplicity considering treated and untreated, but we can have more than binary treatments. We have potential outcomes. And again, we observe only one of the outcomes depending on the decision that we make, the treated outcome or the control outcome. On the basis of this, we are able to estimate the effect of treating a patient. And again, we need to estimate this effect even though we do not observe counterfactuals. We can estimate on the basis of this both the average treatment effect, but what's even more interesting is that we can estimate the individualized treatment effect, also known as conditional average treatment effect. And here we are conditioning on the patient feature Xi to estimate the effect of a treatment. It is probably a more correct term to use the term conditional average treatment effect, because the reality is we condition on these features Xi. So it is not really individualized to this patient, but rather to the entire subgroup of patients that have this particular set of features X. I wanted to also say that we make two assumptions here. I'm not going to go into the details of them, but I want to mention that we are able to do that only when we make two assumptions. One is that we have no hidden confounders in the data. And of course, this is a quite strong assumption. And the other one is the fact that we have common support. So for a patient set with features X, we observe both the treated and untreated subgroup. So we are able hence to learn. Once again, this is a causal inference problem, and this is a problem that has been studied for more than 100 years. There are many good books about it. One of my personal favorites is a book by two statisticians, Hernan and Robbins, and it's called Causal Inference, What If? Extensive work has done in the statistics and econometrics, again, for many, many years. And this is a problem that econometricians also especially take a good look at, because this is about interventions that could be economic interventions in an economy, not only in medicine. So at this stage, you may wonder why machine learning? What has machine learning to add? The reason machine learning can add a lot to this agenda is that due to its flexibility. So we are able to learn very effectively from complex data sets that may contain multimodal variables and may contain a large set of variables. We may be able to learn very effectively from observational data. Also, we can model very effectively the treatment assignment variables. And also, we can deal effectively with selection bias by training very carefully and effectively in the presence of such selection bias by identifying crafted loss functions that can train machine learning models effectively. I'm not going to bother you with the details. I'm going to say that the work on machine learning for causal effect inference is relatively recent, only 5 years ago. The recent work has started by work by Shalit, Sontag, and Johansson and Sontag, a group at MIT. And then our own group has done quite a lot of work in this area. You see here just a few of the works, but we have done work not only on binary treatments, but also on multiple treatments, continuous treatments, as well as more recently combining ideas from clinical pharmacology with machine learning. One particular work that I have highlighted in a previous session on revolutionizing healthcare was GANITE, which was a framework that we have developed for individualized treatment effects to estimate what would be the best for a particular patient in the case we have more than one treatment. And this is using a very powerful machine learning idea based on generative adversarial networks. I will not, in view of time, tell you too much about that. Just I want to say that, again, our group and many others are very active in this particular area, developing new machine learning methods for personalized therapeutics. And finally, I want to just say that this is not only interesting in a static setting, but also in the time series setting, where you may have longitudinal trajectories about a patient, both static variables taken at the time of the diagnosis of the patient, but also other information that may be acquired over time, inclusively potentially different treatments that were given and interventions that were given to a patient. And this forms the patient history. And on the basis of this patient history, we are going to be able to estimate the effect of different treatment plans and interventions into the future. So we can do causal effect inference and personalized therapeutics over time. And in this way, we can decide for a patient when to treat, what's the optimal time of the treatment, when to stop a treatment, and what type of treatments and interventions we should give over time. We could look at that with respect to multiple outcomes, both primary outcomes, such as, for instance, survival or tumor volume or side effects. And again, we are learning methods that are able to make such predictions into the future. Again, as in the static setting, this is not just a prediction problem, but rather a causal effect inference problem, and we are able to compute counterfactuals. If anybody that you are working with or are interested to try some of these methods, especially in the time series setting, which represents the most advanced setting, we have recently built end-to-end clinical decision support that we call clairvoyance. And this system was built together with Ari Ercole, our clinical collaborator in Cambridge. And the focus here is to do not only predictions, but also treatment effect estimation over time. So some of the methods that I mentioned before, Ganite, as well as some of the time series models, are part of this package, which is an open source package that you can try yourself. If you want to learn more about that, we have a website dedicated to this topic where you can learn about what is possible in the various settings and what are advantages as well as limitations of these methods, such that you hear about state of the art, what machine learning can do. And if you want to read just one paper to get familiar with the topic, I would recommend this tutorial paper, which I have written together with two of my students and a collaborator, a pharmacology collaborator, which introduces in a tutorial fashion in the Clinical Pharmacology and Therapeutics journal this idea of using machine learning for individualized treatment effect inference from observational data. It is not too difficult to read and may provide the first basis. If you want to read more, depending on your level of familiarity with the topic, we have built an entire tutorial about the topic, starting with fundamentals, theory, algorithms, applications, as well as advanced topics. So if you have time and interest, you can take a look, depending on your level of interest and familiarity with the topic, to these different components at the website that we have created, where we have tutorials associated with this exciting topic of individualized treatment effect inference. And again, I'd like to highlight that this is different than what you may have heard so far about supervised learning, where we just issue predictions. Now we can go one step further and move into this new field of personalized therapeutics using machine learning. I'm now going to stop and share screen. And if you allow me, yeah, so I think.
So yeah, I'm just going to pull up a quick slide, just reminding everyone who our panel of clinicians are, and also basically the way this roundtable will work is Mihaela will kind of guide our panelists through a number of topics based on the questions that you'll see here. And yeah, once we've kind of read them out, I'll stop sharing my screen, and then our panelists will kind of discuss these topics that Mihaela's just broached.
So thank you. So thank you again very much, Camelia and Lucas and Neil for joining me in this discussion. So I prepared here a few questions for you, and this summarizes questions that we in general, the machine learning community, kind of are struggling with, and would like to hear your opinion. First is more along the guidelines you are using and possible limitations and hence need for the tools like the ones that I described here. And I grouped this into a first set of 3 questions. How often do you have to make treatment decisions on behalf of the patient in front of you based on a limited number of variables? For instance, you think the treatment guidelines recommendation is not personalized enough for the patient in front of you, and you could have done better by personalizing the treatment decision to the patient. A second question I have related to it is, to what degree would you like to make more refined, personalized guidelines for treatment recommendations for individual patients? And finally, to what extent do you feel that the guidelines compromise what medicine should be able to do for the patient in front of you? I don't know, shall I start with you, Owen?
Sure, thanks. Thanks for the great introduction, first of all. I guess to pick up the first idea of how often we might work outside of existing guidelines, I think from my perspective, almost always. I think it's part of the skill of being a doctor is where you might not know you're doing it, but you're essentially trying to make an individualized treatment effect decision based on your clinical experience by filtering the existing evidence and trying to apply it to the individual in front of you. Now, that it basically is what it means to be a doctor, and it's why we can't just follow an algorithm, but it's fundamentally limited by our own personal experience because you're trying to sum up the patient in front of you who you don't always know everything about, and you're trying to apply your own limited experience and biased experience. I think that's where systematically broaching that problem with individualized treatment effects could be massively helpful. I think it basically stands to offer an awful lot by taking the extremely crude guidelines that we currently use and applying them to the individual person. It's worth also mentioning that particularly with an aging population, for example, the number of patients that we see that sit outside of conventional or common inclusion criteria for the studies that are the building blocks of our evidence base, that just happens increasingly frequently. So I think this is going to be an increasing problem over time as well.
Anybody else? Camelia? Neil?
I agree. I would say that every day, every patient that I see, there's a level of decision making that's based on a limited number of variables, and just referring to the guidelines is always helpful as a framework. But it's a daily problem for a practicing physician, and I know that the guidelines are different in different countries. So that poses even a more complex problem because what I would recommend, for example, for breast cancer screening in Los Angeles at UCLA may be different from what a practicing physician in Cambridge recommends to a similar patient. So I wouldn't use, in your question, you use the word compromise. I'm going to quote, to what extent do you feel guidelines compromise what medicine should be able to do? So I think that's a very strong word. I think the guidelines are helpful in offering some sort of standard to practitioners that would hopefully reduce some of the tremendous bias that each of us has when we approach an individual patient.
I guess that's a great lead in for Neil, so who looks also at variation in practice. So I guess, Neil, I'd be very eager to hear what you think about this.
Thanks, Mihaela, and thanks once again for the invitation to join. So I suppose like every clinician, we all come with our own biases, as you've just said, Camelia. Mine is looking after patients with lung cancer, and I chair the National Lung Cancer Audit. So we do, I have some experience of looking at the bigger picture in terms of how patients do and applying that to our individual patients. But going back to the question of guidelines, I think is one of the key limitations for me of guidelines is that within guidelines they don't take into account comorbidities. And every patient that we see, and particularly in my world, in the lung cancer world, every patient comes with their comorbidities, not to mention their own personal biases, their own experience of events that have happened to people they know, as well as our own biases. And I think it's very difficult to take into account those things when we're faced with a patient just using the guidelines. So I think comorbidities, I think, is one really key area that is often omitted from guidelines, that I think your work really is potentially has an enormous potential power to influence.
Lucas, I don't know whether you want to add anything, or we can go to the next set of questions.
Yeah, no, I think what's really interesting, what's also mentioned by the other doctors, is that in clinical practice, more and more we see a diverse selection of patients from all walks of life. And I think I work in the intensive care unit, and especially there's a large heterogeneity within the patient population. I think these guidelines are built ideally on high-level evidence, randomized clinical trials with all the limitations that you discussed in the presentation. And I think especially also in the intensive care unit, we gather so much data from these patients that it's, for a doctor, it becomes more and more impossible to sort of have all this data in their mind and their brain before taking these decisions for an individual patient with this diverse background. So I think there's a lot of room for these techniques in the intensive care unit.
Lucas, what about especially the time series setting? Because especially intensive care setting, there is a lot of observations like you mentioned. How do you think about applying guidelines and the type of guidelines for such more dynamic environments like the ones you have, which may be even more dynamic than in a cancer setting potentially?
Yes, yeah, I think in every medical setting or in most medical settings, there's sort of this follow-up, whether out clinic or within the clinic. I think the unique part to the intensive care unit is that it's so continuous, and there's so much data that's being gathered continuously from our patient and also from monitors. So it's not necessarily hidden away in clinicians' notes or nurse notes, but it's right there from the ventilators or the monitors. And I think what's really nice, we have a lot of time points where ideally we would take decisions or we'd monitor our patients, but we can use all of that information that happened before to feed models, to feed these individualized treatment models to make good predictions about treatment for our patients. So I think that's sort of the added benefit of these models that they can really have in clinical practice.
Thank you. Nick, I see that there are some questions actually in the chat. So maybe before we move to the second part, we can ask Karen to ask the questions, maybe.
Yeah. So Karen, if you wouldn't mind just unmuting yourself, then please go ahead. Karen, I think you may still be on mute. I've just asked you to unmute this. So there we go.
Can you hear me now?
Yes,
I can.
Sorry about that, and thanks for the presentations. I think my first question you actually then covered in the latter part, and I can look at your representation learning abstract from last year. And in terms of from the second aspect, I think as clinicians, the idea of counterfactuals is very interesting, but how do we assess the reliability? Because that's the key part of this.
Thank you so much for this, Karen, for this question. This is a question I often debate, and I'm going to give some answers, but I had a lot of discussions about this with Eun, who is here as well. So I'll give some answers, but I'd be very eager to hear his thoughts on that myself. So we usually in the machine learning community, we are assessing these counterfactuals in a few ways. We either look at the factuals only. So if we have prospective data, we are going to only see whether the predictions that were made were indeed, given the decisions that were taken on what treatment to use, we indeed predict the same factuals, and we indeed predict the same outcome. And moreover, that indeed we predicted that the counterfactual would have led to a less good outcome. That's one way. Another way is we use often semi-synthetic data. So we use randomized controlled trials that we then bias according to a particular decision that would have been done in a clinical setting, and try to see if we can uncover in this, on the basis of this randomized controlled trial, the correct counterfactuals. These are two ways in which we currently in our community measure the efficacy of these counterfactuals. But I don't know, you also have thought about that, so.
Yeah, I think it is a great question, and it's not just a question for machine learners, but it's a question for us to try and estimate what will be acceptable to the medical community as well. Because for these models to have impact, they have to be acceptable, and people have to understand them sufficiently in order to make them used. I think exactly what Mihaela said are really important concepts. One idea that we've also been talking about is whether a prospective evaluation of an individualized treatment effect approach, a bit like a randomized trial of the method. So with people randomized to an individualized treatment approach versus standard care is feasible. I think that's a nice idea, and it in some ways brings the two worlds together, the future and the present. We've been continually reliant on randomized controlled trials, so to put ITE in that framework, and I would expect it to outperform standard care, given that it will be allocating treatment on a personalized basis. It would be really exciting, and I think extremely powerful and convincing for the medical community to see ITE tested in that slightly more conventional way.
And just to follow up on what Ern said, another area of our research and other researchers like me is in looking at providing not only estimation of treatment effects, but also confidence guarantees associated with these predictions, such that we know for what class of patients the machine learning model is confident in making these predictions, and for what class of patients it is not. So that may be another way of looking at it.
Perhaps we have just one other quick comment, which is that using, and it sounds a bit counterintuitive if you like, but using ITE estimates on existing observational data to recreate existing randomized controlled trial results. So it's counterintuitive because you're effectively using individualized estimates and summating them to give you a randomized controlled trial, so to give you the average population level estimate. But that can be reassuring, and in fact has been done by Mihaela's group on some historical pieces of work. So, you know, recreating trials in a different population to show a similar result, not just a similar result, but a similar magnitude of an average treatment estimation by summating the individual facts. I think that's encouraging and suggests that this really is going to work.
Okay, that's great. Thanks very much.
Thank you, Karen. So maybe in view of time, I see many other questions, and I think we will go through them either this time. I'd like to kind of go to the next slide, Nick, if that's possible, that I prepared for our panelists, which goes along the lines of some of these questions that I see in the chat, but maybe sets the background. So is, how often do you need to decide on a management of an individual using personalized judgment based on guidelines? I already kind of asked that. And when do you make such a decision, how confident are you that you have the data to support it? And do you think personalized therapeutics, individualized treatment effects could replace clinical guidelines for prescribing treatments? So do you have the data to support it? And do you think that this can maybe replace in the future even guidelines?
Yeah, so Mihaela, we often make clinical decisions, I'm afraid, without the quality of evidence that we would like to support them. Certainly in my own area as well, there's often no clinical trials to guide us, or as we've discussed, the subset of patients we don't have very good evidence for. One example that I come across every day in my clinical practice is about follow-up of lung cancer patients. So sadly, we have no very good randomized trial data, we have guidelines that vary internationally, and unfortunately practice is varied internationally as well. So, you know, it's just an example of where I think this technique could be incredibly valuable and really, I think, improve clinical care relatively quickly.
So what I do is primary care internal medicine. So I would think that, Neil, you're more fortunate than I am to focus on a specific problem with more appropriate guidelines. But for example, in the United States, one of the most common reason for people seeking a medical visit is fatigue. And as practicing physicians, we all know that that's a very common symptoms that can be caused by a variety of different conditions. So there's really no guideline to tell us. I mean, we have I guess a thought framework on how to work that up, but it's very difficult to practice in a you know, a guideline frame setting with such symptoms. You know, fatigue, insomnia, these are very common symptoms for which millions of people seek medical advice, and there's no specific guideline for that. So of course it would be great to have more personalized and more refined guidance for common symptoms like that.
Camelia, just to clarify one thing that may be a little bit misleading from my terminology, when I mainly refer to guidelines less for diagnosis, I'm clearly very aware that guidelines for the path to diagnosis is complex as well, but I was mainly referring to guidelines for treatment because of the discussion we have today on personalized therapeutics. So especially for guidelines for determining whether you should intervene or you should wait, and maybe for how long should you wait. So I was kind of curious what you all think about that, because a decision, for instance, not to intervene, it's by itself a decision.
Absolutely. I think it's also quite important to recognize that the minority of circumstances where there are guidelines, so most decisions we make, there are no guidelines for, I think that's clear. Even where there are guidelines, and even where the individual you're seeing falls within the remit of those guidelines, often the guidelines include several levels of evidence. And many of those guidelines will have evidence level C, which effectively equates to a small group of experts sat in a room and decided that they thought this was best. And that is nothing more than an attempt to distillate clinical opinion from a small number of people. And in effect, an IT algorithm can garner a huge, vast amount of experience, way more than a small number of people, and give a much more balanced and unbiased estimate of how an individual should be treated. So I think we need to be aware of the major flaws in the guidelines themselves and the way they're constructed, and not, it's easy to rely on them as a crutch and think that you're doing the right thing by following the guideline. You may well not be, and it's important to be explicit about what we don't know.
I saw quite some questions in the chat. I think most of the questions raised by Mehdi have been already addressed, but Mehdi, if you have another question, maybe you can ask it.
No, thank you. Actually, yeah, you're right. Actually, you answered most of my question. Thank you.
Thank you. And I see that we have another question by Zhiqiang.
Yeah, so if Zhiqiang, if you want to go and unmute yourself, would you mind asking your question, or are you able to? Not, I guess not everyone has access to a microphone all the time. I could read it out if you want. Okay. So yeah, Zhiqiang's question was, with a well-trained model using the historical database, how to gain trust and persuade the clinician to use the suggestion given by the machine learning model. While making a treatment decision, how to make a trade-off between clinician domain knowledge and machine prediction.
This is a good question. I guess I'd like to pass this question to Lucas, that is looking at some of these issues together with us as well as by himself. So Lucas, maybe you would like to take this one?
Yes, definitely. I think this is one of the core sort of concepts that, you know, we're trying to sort of work out in this area, is how to make these individualized treatment effects, how to make it also resonate with clinicians and not have them be completely out of line with what is standard in practice. Or so I think it's a very good question. I think there were some suggestions that were posed earlier. What we're now doing for one of the projects is we're looking into more of the mechanistic framework. So can we say something about, you know, if we make a certain prediction, like how would that fit into the disease mechanisms that are at play, to gain some more insight of what's happening in this particular patient. I think also what was mentioned before is the confidence estimates. So if we make certain predictions, how confident would a model be about certain predictions that it takes to sort of bridge that gap between, you know, the model and the prior knowledge of clinicians.
Thank you very much. Maybe, Nick, in view of time, we can go to the last slide that I have, and then we can continue with questions. So my last question is more about the opportunities. So which diseases or therapeutic areas do you think would most benefit from such a personalized therapeutics, individualized treatment effects, decision support system? And what information would you like to see about the machine learning models potentially being used for personalized therapeutics in order to convince you, the clinicians, that these models provide useful information for the patient in front of you?
I could start off if you like. I think these are two great questions, and I really like them because they get to the heart of how this might be used. For me, the context, I was thinking about the characteristics of the context in which the IT approach would have most to offer. And I think it's where your treatment response is highly heterogeneous. So it really is hard to predict. You've got a wide distribution of possible responses. And also where the cost of that treatment is high. And by cost, I mean either financial cost or the risks. So if you have a treatment that's high risk or high toxicity, and you don't know for sure that it's going to work, but it might work. And I guess in the context of cancer therapy, there is a lot to offer there, where there's a potential high benefit. There are variable individualized responses. The treatments are often high cost. But also there are substantial toxicities involved. So if the patient is not going to respond, then actually you don't have much time to give them a treatment that they will respond to, and you don't want to expose them to the toxicity of that treatment either. So that's one context in which I think there's a lot of data on which to found a lot of observational data on which to found the training of the models, first of all, and there's also potential for improvement on existing algorithms and guidelines. I don't know if you'd agree with that, Neil.
Yeah, no, I think that's a really great answer. I think in terms of getting this into clinical practice, though, I think we do need more than the derivation and validation side of things. I think we do need a prospective study. You alluded to a randomized trial, but even with a qualitative element perhaps, where you interview, as well as collecting the hard data and the outcomes of 1 year survival, etc., or whatever the primary outcome would be. It would be really valuable, I think, as well, to have some qualitative data from the intervention. So what is the impact on the clinician? What is the impact on the patient? Are patients going to accept this? They have to accept this technology as well as the clinicians. So yeah, but I think if that can be achieved going forward, I think this is going to have an enormous impact, potentially, particularly in the cancer world generally.
Can I follow up with a quick question there? If just to sort of be to provoke, how convinced would you be if ITE was able to estimate, as we said, an average treatment effect and reproduce a previous clinical trials result on observational data? Would that be sufficient to convince you that it is robust enough to use for individual estimation in real practice, or would you require prospective validation and a head-to-head study against current practice? I guess I'm sort of asking that as an open question to any clinician rather than anyone specific. I'm not sure of the answer myself.
I'm going to answer because, you know, I think my perspective is of a practicing clinician who doesn't have a good enough background in machine learning nitty gritty. So, I mean, I would have to say that that would be a very compelling evidence that would make me more likely to accept it. But at this point, I'd still like to have a head-to-head prospective trial.
I think if I can respond to that as well, I think it's very interesting it's a topic that, you know, as practicing physician, what if the model takes a decision for your patient, you would sort of accept that decision? Then what if something goes wrong with the patient? They come back to you, like, how does that influence us as physicians? Like, was it the, you know, the machine's decision, or was it ultimately our decision to follow that guideline? I think those are also things maybe that is also a little the qualitative part that that Neil's talking about, that we need to evaluate. How does that work in practice?
Let me just interject to say that I really like that challenge, Lucas, and I will take it in a subsequent Revolutionizing Healthcare session, because I think that's interesting by itself. If clinician and algorithm cooperate, how should they cooperate, and how should they become a partnership? But I will leave that for a next topic. Sorry. I don't know, Camelia or Neil, if you want to respond to the challenge of further. Actually, Camelia responded already, so Neil, I think it's you are the only one.
Yeah, I can see my medical insurance bill going up if I, you know, with their algorithm being part of it. But yeah, I think
or maybe
it's going to be. Well, yeah, knowing insurance companies, I suspect it will go up initially. I think in time, maybe it will come down. But yeah, I think it's difficult for me to get past at least the initial stage of a prospective clinical study to show the clinical utility of this. I think that's going to be difficult to get past and not do that. I don't envisage it being a hurdle or too much of a barrier. I think if you were to choose patient-orientated outcomes, add a qualitative study to it, I think actually it could be a relatively small but highly persuasive study with potentially a big effect at the end of it. So yeah, I would still sort of say we need a prospective study, in my view.
Thank you. A brief final question that was on the slide was, let's assume now that this study has been done. Let's assume that it has happened. Still, what would you like to see in front of yourself to convince you not to convince you to use it, to know how to use this method? What type of information would you like to see? For instance, information about the patient's unique characteristics that have been taken into consideration when issuing this type of recommendation for different treatments? Would you like to see, what type of information would you like to see for the patient in front of you and for the decision support as to why a particular recommendation for intervention has been issued? What would you like to see? I understand the validation part, but let's assume that it has been validated. I'm curious what information you'd like to see.
I think in my clinic, when I'm talking to a patient, I want to see a selection of outcomes with, a selection of outcomes based on some appropriate treatments. So if we were to give radiotherapy, this is what a range of outcomes might be. If we were to give surgery, this is what a range of outcomes might be. This might be the impact on quality of life and so on. So I think rather than saying this is the best outcome, or this is the best treatment rather, it would be really important to know and to see the options that the algorithm is going through, rather than just to churn out an output to say radiotherapy is the best treatment. It would be important to be able to discuss those options further with the patient, and really powerful to know some of what the quantitative outcomes might be for that patient, given the treatment options.
Yeah, I think from my perspective, the two, or perhaps the two most important things would be competing risks that you mentioned before. So I'd really like to know that if for whichever option we're considering, what are the pros and what are the cons? That you may have better outcome, but actually that comes at a price, and that price is recurrent treatments, more side effects, and also a confidence estimate. So some form of confidence estimate in how sure we are of that prediction. I think those two things would be very helpful.
I think also a little bit relates to the work that we're currently doing is I think it would be really nice if the models could show why certain decisions are taken. Like, are there certain characteristics in this patient or certain mechanisms going on that make a particular treatment more appealing versus another treatment, to sort of resonate with, I think, the way we clinically think about patients and certain characteristics from our patients or red flags that we see in our patients. Like, why is it that a certain treatment algorithm would, like, take a certain decision?
Thank you very much. I think we have quite a few questions, and I think Tom has a question.
Yeah, it was just, so if you've got a training set and your patients have a clinical feature or variable that's unusual or outside of the norms, can these models cope with that? And then particularly thinking that your patient might have multiple variables that are at the extremes of norm. If you think about, I don't know, comorbidities, there's always going to be a long tail of unusual comorbidities that people might have, aside from, say, the common ones like diabetes. And if you have those problems, does that compound and does that trip up models like this, or is this actually just routine fodder for these algorithms?
Thank you. So no, this is again very good question. Thank you, Tom, for that. So no, definitely. So we are learning on the basis of whatever data is available. If sufficient patients with these unique characteristics are there, we will be able to learn from them. But if they are not, we will not be able to learn. So that's exactly kind of what Owen was saying. Maybe for the subset of patients that you mentioned, we will say we do not have enough patients with these characteristics that have been treated in various ways. We are not confident in the prediction. Or conversely, we were able to learn from a sufficiently large population in whatever electronic health records or registries, and are confident in this prediction, maybe for this treatment, but not for this other treatment.
Okay, so it's sort of environments where you've got a lot of data, but perhaps we can't process it, like the ITU scenario or routine blood testing.
Machine learning methods are learning from whatever data is available. If the data is not available and these patients are truly unique and we have not seen patients like that before, it will be difficult. Another thing I should say, though, that helps a little bit with it is that we are learning what are the unique features of the patient that are most predictive of a particular set of outcomes for a particular treatment. So the main outcome, but also, like Owen said, side effects. So then we could say it is these features that of the patient that have led to this prediction for this main outcome and for this competing risks. And maybe these features are already there for the patient in front of you, but there could be that other features play a role, and yeah. So
the one thing I was going to add to that, Tom, is that it's probably worth bearing in mind in that specific context where you've got an outlier patient, that you're going to have to make a decision on that patient. And whilst they might not have been in the training set for your algorithm, they probably aren't also in your clinical experience repertoire. You've probably never seen someone with that condition either, because it's rare by definition. So you're going to have to make a decision on limited information either way. So it's not that different to the situation in which you find yourself anyway.
Thank you so much. I see quite some other questions. One question from Karen I can take very fast. So that's a question about using NHS Predict as opposed to some of these methods. And the answer is we have already done that, Karen. Thank you for that. We have a system that we call Adjutorium, where we have compared some of these machine learning models as opposed to NHS Predict, and we are able to show significant performance improvements as opposed to Predict. And this paper will appear relatively soon in Nature Machine Intelligence. So just follow our website and you will see some of that. So yes, we are already starting to compare. I see a question from Henk. I'm not sure if Henk
he's still on, and I think, yeah, we can ask him to unmute and ask his question if he wants.
I'm afraid he may be in clinic, so maybe not. Hi, Henk.
No, Henk is not in clinic. Henk is in home.
That's fantastic.
Yeah, I think, well, we are discussing quite difficult problems at this moment. I mean, if you look at therapy for breast cancer, I'm a general practitioner, so I don't know how many different therapies there are, but I know there quite a bit. And well, my suggestion here would be, why not take a very simple problem like I propose some ENT problems, because that's the most simple problems there are on the world, I think, like removing adenoids or placing ventilation tubes or something like that. They do that millions of times a day, but nobody knows why. And still it is not known whether it is effective or not. And there have been many trials, and not one single trial can give you an answer for that. So it might be just the case that a method like Mihaela is now proposing can give an answer. And if you are able to provide an answer on a question like that, you will, I think you will gain much much more confidence in your methods anyway, by the rest of the world, not by ENT surgeons maybe.
Let's do it. I'm then I'm open call then for any clinician that has such a data set and interest to let us.
Maybe Mihaela, we should write a few people. Maybe we can find some ENT surgeons who are prepared to do it.
Wonderful.
And can provide access to the data. That's the most important part, I think.
Thank you, everyone.
That was more of a suggestion, because I think that all the problems concerning chemotherapy and cancer treatments that often are much more complicated. So there are many more variables in, not so much more variables, as more medical variables are concerned. So. And I think if you look at the magnitude of the problem, this one is a very large one. All those mistreated children.
Thank you so much.
That's also for my colleague GP.
Yeah, I see Camelia nodding about that. So thank you so much, very much, Camelia, Lucas, Ern, and Neil for this very good discussion and for engaging with me on this topic. Nick, I guess you'd like to finish this session? And thank you everyone for participating, of course.
Left myself on mute there for a second. So just before I go, just to give you a quick idea of what to expect from our next sessions. Our 9th session, we currently have kind of tentatively penciled in for early July. We'll keep you up to date with how our thinking on that evolves over the next few days. Also, I do plan, of course, to edit and upload this session to YouTube, so I'll share that with you. And as I mentioned before, we do have a piece of upcoming content on interpretable machine learning for healthcare. This actually draws on our previous 2 roundtables, so I'll also send you that in the coming days. For those of you who do want to claim CPD credits, all you need to do is basically just email me at the address that you can see on the slide right here. or you could just reply to any of the emails that I sent to you regarding Revolutionizing Healthcare. Just let me know which sessions you've attended and whether you saw them live or archived, and I'll put together a certificate and send it through to you. Also, do let your friends or colleagues know about these sessions if you do happen to know anyone who might be interested in them. Obviously, we're trying to build an interdisciplinary community, and word of mouth is extremely important in helping us do that. Other than that, I'd just like to thank all of you for joining, and to thank those of you who put questions or opinions or helpful comments into the chat. And of course, I'd like to give a huge thanks to our 4 panelists for joining us today and taking time out of their busy schedules to be with us here today. In the meantime, I'm very much looking forward to our next session, and please do take care and stay safe. And until then.